Welcome to Advanced Patient Care, the exclusive podcast series by Vance Thompson Vision. Our purpose is to keep you at the forefront of patient care through dynamic insights, practical clinic tips, and engaging expert discussions. Join us on a journey of continuous learning and professional growth as we delve into the latest advancements in ophthalmology and optometry. Our mission is clear: empower eye care providers with the knowledge and tools needed to deliver exceptional patient care. The Advanced Patient Care podcast is dedicated to elevating our craft, one episode at a time.
Hi, everyone. Thanks for joining us for another round of Advanced Patient Care with the podcast series by Vance Thompson Vision. I'm Brooke Messer. I'm an optometrist, and I practice in our West Fargo location, and I'm excited to be with you all today. I am joined by one of my favorite people in our organization. I'm joined by Dr. Vance Thompson. He is the founder and father of our clinics and our organization, and I'm excited for you to be here with me today. For those of you who don't know Vance, maybe one of the best things about him is that he is a fellow myopia enthusiast and really pushing the needle on the awareness of the importance of myopia in both optometry and ophthalmology. And as an optometrist working alongside an ophthalmologist, I thank you, Vance, for everything that you have done to build the awareness of myopia in both optometry and ophthalmology, because you recognize the importance of the dangers of high myopia. And so I'm really honored to have you with me today and to just bring your perspective to our discussion. So welcome, Vance Thompson.
Thank you, Brooke. It means a ton to me to do this with you because, as you know, one of our foundations and one of the reasons we're on the same team is we care deeply about doing what's right for our fellow person, whether it's our patient or our teammate. So this, idea of, a team who, really is taking care of each other to create an environment where patients feel taken care of is foundational. And so for us, this myopia aspect and some of the health aspects that can be, enhanced and problems prevented through what you're doing is gets to our core principles. So for me, you've brought so much to this team that started out little and got big because of talented people like you and the patients you're attracting from all over and the doctors that you educate, around the world. So I'm honored to be here with you.
For those of you who are less familiar with us, Vance practices in our headquarters or our flagship clinic in Sioux Falls, South Dakota, and then I am a short jaunt north in West Fargo, and these are some great pictures of our clinics. And in Fargo, we do have the nice, beautiful halo lights too, and that in our new clinic here, just about a year old. It's really fun to have that, and I just didn't have a great picture of our clinic at nighttime, but the clinics are just really beautiful, and that's another highlight of being here. But anyway, moving into the myopia highlights for 2025 and 2024 for me, as you mentioned, the myopia clinic aspect in my practice is growing, both in teammates that are invested, they're curious about our patients, they're becoming more comfortable talking to young patients, because we'll have some as even young as 6 or 7 years old coming in to have their myopia evaluated. We've evaluated a 1-year-old for axial length in the past year, and I just really appreciate the investment of my teammates. They're treating our young kids with cute little gifts to reward them for their work on taking good care of their contacts and their eyes. So that's been really rewarding. We're also seeing referrals from, locations a little bit further away. Some come from, as far as like 2 or 2.5 hours away. And so that's been a big highlight for me. I'm sure, Vance, you've been there on, trying to bring something new to an area. And when you start to see like your community support your efforts and you start to see patients come in because the community is committed to the same thing that you are, and they just recognize that, hey, like this patient needs more than what I can provide, and we build that co-management relationship around these patients, it's very rewarding, whether it's myopia or something else, glaucoma. And I'm sure you feel the same way when you put those efforts into your locations and communities.
Well, and indeed, Brooke. And so starting something isn't easy, but our motivator first is recognizing there's a problem and an underserved population, and then doing it as a team. Like you're doing, working with the doctors of the region to help serve the patients of the region, and then actually seeing the needle move and seeing the doctors appreciate it and the patients appreciating it. So, bravo to starting something important.
Yeah, it's been really fun and very rewarding. The other thing that I think is neat, to add to my highlights is the identification or the recognition of what we call a pre-myopia status in young kids. So these are kids that are 6 or 7 years old, or perhaps even younger, and they're lower than that, like +1 or +150 typical emmetropization pattern. And so when we have young kids, they may still like measure hyperopic in the phoropter, but they're less hyperopic than they should be. That's the status of pre-myopia. And there's a lot of good data out there on pre-myopia and using treatments, something like atropine drops, to push off that tip of the needle into a myopic refractive error, and try and allow that eye to catch up to the emmetropization process as the child grows. So I think the identification of pre-myopia and the discussions around it has been impactful. I'm sure my kids are probably on the path. They're both around a +1 still, but they're both young, and both my husband and I are myopic. And so I'm highly invested in that topic as well. And then lastly, I've been working with an orthokeratology lens for a company for about the last 5 years, and we finally got FDA approval. Or I shouldn't say they got FDA approval. I was just lucky enough to be one of the providers to be able to use the lens and provide the support they needed to bring the lens to the FDA with good data and get that approval. And so that's been, that's a very rewarding process, and I'm excited to see that come available to patients because it was a great experience. And here's a video that I have from a kiddo wearing that lens. And so we'll go ahead and share that with you now. I think regardless of brand, it could be brand A, brand B, brand C. The neat thing about orthokeratology is that kids absolutely love it. And it doesn't matter what lens they're wearing, as long as the lens is working and it's fitting well, these kids are going to absolutely thrive. And so again, the message here isn't so much around the brand itself, it's more about just what it can do for kids. So we'll go ahead and watch that. It takes about 1.5 minutes, so we'll watch that now.
It's my number one option. They're definitely at the top. Arise changed my life.
In the end, Arise basically changed my life for the better.
Hello, my name is Eli, and I'm 11 years old. I'm definitely a sports kid, an athlete. I love to do sports in all my sports, whether it was, football or baseball. Some of them required a helmet, and I remember having glasses on with a helmet, and that was really hard because it was just really tough having to pry the helmet open. But with the new Ortho-K lenses with Arise, it allowed me to, to be able to do so much things that I never thought of were possible before. I could see everything clearly with my contacts on, no glasses. It was definitely a huge moment for me because I knew that, I had done it and I didn't need glasses anymore. Waking up and going to school and not having to worry about where I'm sitting in the class or how big the print is on the screen or anything like that. Arise has allowed me to see things a lot more clearly. We had a discussion, what would be the first thing you would grab if the house started on fire and you need to grab something? And I said my contact lenses. My Arise lenses is what I would grab. So one of my most important things, Arise lenses have been life-changing for me, and they're incredible, and I recommend them to any other kids out there like me who, just are sick of glasses and want to try out something new.
So as you saw there, Eli, my patient, you know, he's a sports kid and just loves the freedom that orthokeratology brings from glasses for him. And, you know, the kids love it because they get the freedom from glasses. They love the ability to, you know, run through the sprinklers, go swimming, play football without glasses on, where the parents, you know, they know that they're doing the right thing for protecting their kids' eyesight into adulthood. So I love, like, rather than being a double-edged sword, it's really, you know, have your cake and eat it too, where we get both benefits on the parental side and the child side. And that's probably the most rewarding thing about orthokeratology. With Vance, I know that I think something really interesting is that you've been involved in Ortho-K for a long time. Just, you know, again, like, it seems a little unorthodox for a surgeon to be interested in Ortho-K, but can you tell me where your interest in Ortho-K like began and how you got involved? And, you know, you're very close with some of the orthokeratology lens companies and help them with their medical advisory and things like that. Can you share with us how that all started?
Well, you know, being a refractive surgeon, someone who has dedicated his career to that aspect of eye care, I've always been fascinated with glasses and contact lenses, basically wanting to help patients get what they desire. And so if someone's happy with glasses, great. If they're happy with contact lenses, great. But that fascination kind of between changing the shape of the cornea as a refractive surgeon and wanting to serve patients that also, you know, care about optical devices kind of came together with orthokeratology, because that involves a contact lens that, you know, is kind of a reverse curve to change the shape of the cornea. So the topography or the curvature change that happened being a lot like refractive surgery, but being something reversible. So that fascinated me. And, with my interest in topography and kind of the similarities, I had a company by the name of Euclid ask me to advise them since the mid 90s, and I still do. And so a lot of people have been interested on why a surgeon would be so engaged in orthokeratology. But again, it's about that ultimate commitment to the patient. And so not only do they get that, you know, joy of, if they desire glasses free or contact lens free functioning during the day because of the Ortho-K, lessening their nearsightedness, when we also started finding out that these patients also had less nearsightedness developing than, you know, patients who didn't do Ortho-K. So the myopia management or the myopia control benefit that has a health benefit that we're going to be talking about, that fascinated me even more. So even though I don't consider myself an Ortho-K expert like you, I consider myself an Ortho-K enthusiast, and I actively refer people for it. And that's what I try to advocate in my profession, is, hey, you may be taking care of pathology, and oftentimes the parents of nearsighted children, it's our job to be educating them that you can help prevent their kids from having the problems that they maybe have had from their nearsightedness as an adult.
And again, I think that in the same route, it's similar to me, you know, being in optometry, is the fascination of being able to change the cornea in a reversible way, with the added health benefits. Like you said, it's just, you know, they get the benefits of glasses freedom, and then they also get the benefits that come along with reducing axial elongation and the risks associated with myopic maculopathy and age-related macular degeneration in the future, glaucoma, and things like that. There's, you know, when I was kind of looking at some of the new sources, I was searching for them, and I filtered, you know, 2024 to 2025 only. I wanted to see, like, what's the newest stuff that we can talk about. And I had like 400 papers. I couldn't even pick through, like, what, you know, like, what do I want to talk about? Because there's just so much stuff exploding around myopia management, myopia control, like whatever you want to call it. around reducing that axial elongation and the benefits that come from it. It's such good stuff. And, again, just extremely rewarding. One thing that I would like to highlight, oh, go ahead.
One thing I wanted to add was, even if someone has gotten to the point of, they've been through glasses and contacts, which I still think on the long run is going to still be what the majority of people do. That group that dives into a surgical, they want to explore their surgical options. The myopia management of things like Ortho-K and some of the things we're going to be talking about makes the surgery safer and more accurate because they're not as high of a correction. So, all in all aspects, lessening someone's nearsightedness, whether they want a non-surgical or surgical life, it makes it a safer and better life if we've controlled how highly nearsighted they've become. And so for me in surgery, I know I can do a better job if they weren't allowed to get too high as a child. They have more options as an adult.
Do you think that there's like a safety aspect in age? Like, I'm going to talk about a case here where I started this young patient at 7.5 years old in Ortho-K. And I would say that's average, like 7 to 8 years old is very common amongst providers, at least in the US. Coming from like a ophthalmology, surgical, medical director, even position, do you think that there's concerns with starting something where we're changing the cornea, either from like just a cornea perspective long-term or just the use of overnight wear? Is there a safety aspect in like younger kids, or how do you feel about starting something like this in a kindergartner?
So, my own feelings are that safety is number one, and so it's one of the reasons that we want to be, looking at these various treatments, because if we allow them to go unchecked, then we know that nearsighted people develop cataracts at a higher rate and retinal detachment at a higher rate, and then changes in their macula, where a lot of parents have heard of macular degeneration, but to get an early degeneration is not good either. So we know that nearsightedness left untreated increases the chance of the eyes, shape, size, everything that can lead to these physical changes. So left unchecked, we have safety issues, but we also need to think about the safety of the actual treatment we're going to do. And I'm just not a huge fan of a contact lens in too young of a patient. And so that's where it's good to have different options. And then once that child and their parent have reached that, kind of responsible age, then, contact lenses become more an integral part. And as you know, with wonderful care, like an education like you give, the age, the young age that can happen safely has lowered over the years. And so when you can take a 7-year-old, and do that with a contact lens, that's a beautiful thing. I even think it can really help their, maturation in other areas of their life. I mean, that them becoming responsible and their parents engaged, there's some neat benefits there. But we also know that we want to be starting earlier. And I think that some of the drop studies that we're going to talk about, starting at age 3 or 4, the earlier, the better. And so the art of what you do, when to start that drop at age 3 or 4, when to start that contact lens option at 7, or whenever you deem the situation safe, this is the art, and why having an experienced provider to guide the parents in the art of which treatment when, based on safety and efficacy, is so important.
And I think that's a great sentiment and just mindset around having options. You know, come on, FDA, let's bring those spectacles to market. We've been waiting for those forever too, and that will be a huge game changer for patient access. Um, I have seen that sort of same mindset change over the years when speaking with corneal specialists and things like that, where at first there was a lot of concern about overnight lens wear, and then again, just like the knowledge and the data has come out on, you know, the success and perhaps the benefits outweigh the risks when patients are properly educated on, you know, safe lens use and everything. So that's kind of fun. But moving on to one of the highlights in Ortho-K that I think has come out in the last couple years is the VOLT study. And this has allowed us to kind of ramp up our use of Ortho-K lenses to increase control in a, you know, from a standard Ortho-K design, modifying it to be even more customized to the patient to improve the control over axial elongation. And in this study over 24 months, patients were moved from a 6 millimeter back optical zone diameter, that's like what we call the treatment zone, to a 5 millimeter zone. And those patients progressed 0.2 millimeters less over the course of 24 months, which in our world is impactful. And so this patient here is an example where we started her off. She was doing great with Ortho-K, very happy. Her older sister wore Ortho-K, which is why we started her off. But over 18 months, you can see she had significant axial lengthening, you know, didn't really like the trajectory that we were seeing. She was manifesting minus instead of being, you know, plano or a little bit of plus post Ortho-K treatment. So I knew that she was continuing to change. This was around the same time that this data was coming out, or the preliminary data of the VOLT study. So of course, like I was hyper aware of like, oh, changing optical zones, and there's actually good data around it and that kind of thing. And so I decreased her optical zone to the smallest that I could in that particular design. So you can see we shrunk her treatment zone, kept it nice and centered over the visual axis. And you can see that we flattened her trajectory at the point. So the circled point is where we changed. And then her other two visits, you can see we've pulled that down to reduce her trajectory. And so that is a rewarding case. And something that I think is worth discussing, and we'll kind of come back to it too when we talk about atropine, but you know, prior to this, it was if Ortho-K isn't working and we're still seeing axial elongation, we should add atropine, low concentration atropine. And there are times when I will jump straight from Ortho-K into using atropine and adding atropine to the management. And there are other times where I'll modify the Ortho-K lens itself and then see how it happens. In this case, I decided to maintain monotherapy and modify the lens because look at her axial lengths. You know, she was myopic, but she's still in what I would consider like a low risk axial length zone, being, you know, less than 24 millimeters in her overall axial length. You know, she had a little bit steeper Ks, which is kind of what, you know, alluded to her myopia or her amount of myopia at baseline. But in general, like her axial length is still safe. And so to me, I felt like I had 6 to 12 months to see how she responded to the changes in her Ortho-K design. Whereas if, you know, I have added atropine in and, you know, modified the Ortho-K lens, but adding in atropine in eyes that are more like 25, 25 and a half, where I don't like where they're at to begin with. And I feel like I need to implement control as soon as possible versus giving the child's eye a little bit of time to see how it responds to the new therapy. And that's when I decide on combination therapy versus, you know, modifying the monotherapy. And so the axial, where is my axial length and what is my perceived risk on what the kid's eye size is right now? That is what helps me decide on maintaining one therapy versus combining with another. The next is atropine. And Vance, you were just at ASCRS, and congratulations on your handoff or transition from president to now the outgoing or immediate past president. And so that was a fun meeting, and I was happy to be able to join you there this year. There's a program called Sightline, which is the day before ASCRS begins. And I was excited to see that myopia was actually on the agenda at Sightline this year. Can you share like how the conversation around myopia went at an ophthalmology meeting. Like that's awesome. Can you share a little bit about that?
Yeah. So, the American Society of Cataract and Refractive Surgery that, like you said, Brooke, I just had the honor of being the president of, is heavily involved in the, education and increasing awareness of, its members and the, people that they touch, including the patients of this world. And actually work closely with the other societies in the world. One of the things I really enjoyed about the role was the global impact. And then also a lot of advocacy that happens through lobbying efforts in Washington to, help the future of healthcare with, obviously a vision focus. And so Sightline was a program that was designed that before our annual meeting, and this year it was in Los Angeles, that would help members and industry and participants in Sightline, with kind of some of the, business side of medicine that impacts the way we do things, and so we had different sessions. There was sessions on, cataract surgery and some of the advancements in implants that, have helped people, restore the reading range that they had in their younger years. There was a glaucoma session on reimbursement that our own partner, Dr. Birdall, ran, and there was this session on myopia. And what I loved about it is, like you said, Brooke, this kind of surgically oriented society, recognizing that what comes before anything is the health and safety of the people of our world, and that we're touching a lot of lives in this practice that has, its foundation in surgery, but even more importantly, these non-surgical approaches that can help the health of patients or patients' children. And so a big topic in this myopia management discussion that happened there was our responsibility to be educating parents who obviously want the best for our children, and what are some of the options that are just the modern day ways that the data of really, really good studies have shown can lead to a healthier life for these nearsighted people who, it's growing so rapidly because of our increased use of, cell phones and computers, that, this is now being called a myopia epidemic. And since it truly can damage sight if left untreated, it's going to be felt to be half the world's population by 2050 is going to have this nearsightedness. So this was a hugely important session, extremely well attended, and great to see a surgical organization bringing in important non-surgical things like this.
Yeah, and one thing that I think is continuing to make a splash is low-dose atropine. So there's studies on atropine concentrations ranging from 0.01% all the way up to 1% atropine, and the research world around myopia is really honing in on those ideal concentrations, when to use each kind of concentration, and which population it makes the most impact. And, something that's really neat, just like in any other disease, I don't know that I'm ready to call myopia a disease, but it's certainly a precursor for disease, is, the background of the child, Asian eyes versus African Americans versus Caucasian. And we need to recognize that when we're looking at these studies around atropine and orthokeratology, soft multifocal lenses, that we need to look at the population that these studies were based in. And similar to glaucoma, we know that certain eyes have certain risks related to glaucoma, based on patient background. And so I think it's really neat how research is honing in on the populations that need specific types of treatment. And that would be a pearl I would send home with listeners today is, when you're looking at these studies, be critical of the patient population to make sure it applies to your patient population. Anyway, we'll bring it back to atropine here. Again, like making a big impact, and something that we've learned over the years is that the formulation of atropine really matters, and a company called Signexis is really honing in on that. When it comes to atropine formulation, the drug itself is actually pretty unstable. It's been known to change even within 30 days of being in the bottle, when it comes in a compounded form. And so it's difficult to know that, when we prescribe atropine to patients in the current state, which is from compounding pharmacies, it's better than not doing anything. However, there are some uncertainties in the medication, the amount of medication that our patients are getting with each drop, with the notation that the lower the concentration of the atropine, the faster it degrades. And that there was a recent survey done on, they analyzed a bunch of different bottles of compounded atropine, and they found that they consider like the 90% concentration of the drug, or like 90% of the, within 90% of the desired concentration, that about 1 out of 4 samples were less than that at the time of testing. And so I think about my compounding atropine patients, where they get roughly 6 to 8 bottles a year. And so that means, 1 to 2 of those bottles are not meeting the minimum concentration. And so it's, or potentially not meeting that. And so that's definitely on high alert for me when I think about atropine. And for that reason, I actually see my atropine kids for axial length measurements more often than I see my Ortho-K kids. You would think it'd be the other way around because of the cornea aspect, but I feel like my axial lengths on atropine have just like a slightly higher risk of getting away from me. And so I actually measure them one more time point per year, at least until we get a more standard formulation of atropine, and to be more confident in that patients are getting the same amount of medication with every bottle and every drop that they use. So that's just one pearl around atropine. I'm definitely not trying to talk people out of using atropine, because I do think that for some kids, it's the right choice. Like, they're not ready for contacts. Parents don't wear contacts. Maybe the child has a little bit of like sensory things that they just don't like the thought of touching the eyes, being around the eyes, and then they become non-compliant. And so there's definitely space for atropine in the myopia control discussion, because for some families, it's just better. And doing something is better than doing nothing if they're going to be non-compliant with their Ortho-K lenses. So again, I'm still really excited about the opportunity for atropine to grow in this space. Here's a study from a company called Signexis. Again, they're kind of a player, or a big player, maybe the only player in atropine formulation, and bringing a standard formulation to the market, where rather than going through a compounding pharmacy, patients would be able to go to their pharmacy through a prescription from their provider. And they're really honing in on making sure that their formulation penetrates properly, gets to the receptors that it's supposed to get, so that we can feel confident in what it's actually doing for our patients' eyes. And so it's fun to see that. And for the leaders in the Signexis organization, like, really commit to that and stick with it. And again, it takes a lot of resources to bring a drug to market. And, so we, myopia enthusiasts, are appreciative of those efforts. When we're looking at this, this is one of their studies here, where they were analyzing the formulation. So, the effect of pH, their preservative in the medications, and, the carrier in the bottle, and, so really what's in the bottle of the medication. When there are certain carriers and other things in the drop, that's the purple dashed line. That's the medication that includes a different carrier, where the green line is one that actually has some water component to it. And you can see that the purple dashed line shows that despite having the same concentration of atropine, you can see the effect on the pupil size and how long it lasts before you actually see a real dip in the effect of the drop on the eye. They've already shown that, hey, the change in pupil size with atropine drop is connected to the efficacy of the atropine. And So you can see here that the pupil size change related to their medication sticks around longer. Sorry, my little thing over here is there you go. Sorry, Jamie, somebody doesn't have their mic their mic off on these videos. And Vance, I think, or Vance, was there some discussion around atropine formulation or, within the ophthalmology groups? I know when we were talking about this podcast, you had said Nexus updates, like how exciting. What can you share about, your thoughts on the work that they're doing and the identification around a stable formulation, or a stable formulation, and the impact that it'll have on myopia management?
Well, yeah, so there was great discussion on this because, what happens, it's not like you can't get a good product with a compounding pharmacy, but there's variabilities in different pharmacies, and they're not what we call on label, specifically FDA approved with specific labeling for a patient population that brings a lot of comfort to the doctors and the patients out there. And so we all love the idea of FDA approved product, but we also love the idea of something stable, and it's going to be consistent, and then also comfort. And so the formulation really matters. And so this comparison of kind of a water-based and the deuterium oxide-based product, showing this D2O really having a neat advantage, was an important study, and this study, was the largest study of its kind that's happened, and so to see them meet what we call their primary endpoint, or their primary efficacy endpoint. And if you're a parent out there wondering what efficacy is basically that it's doing what it says it's going to do. And those are the things that lead to FDA approval: safety and efficacy. So you want it safe and you want it to do what it's intended to do. So to have it meet this primary endpoint of slowing the rate of nearsightedness or myopia progression was really exciting to the eye care community. So having a product that you have that sort of confidence in a study that you just don't see a lot of studies that go down to 3 years of age. And so to bring safety and effectiveness or efficacy to a population that young really changed all of our mindset. I mean, a lot of us were thinking of myopia control or nearsight, slowing the growth of progression at a younger age. And so this study has not only taught us a lot about atropine, but it's taught a lot about myopia management in general. And I think really revolutionizing the way we're all going to approach it. And like Brooke, as an expert in this, says, not only can she use it, alone, but she can use it in combination with the contact lens therapies that she does, and that's the art of myopia management or myopia control.
Yeah, I think my next slide is the one on combination, so that's a nice little segue into there. Just to kind of bring you an update on that product, of having a standard formulation versus a compounded one. And again, like you said, I'm not necessarily knocking compounded drugs. It's more about just the challenges around atropine in a compounded formulation. There's a possible even FDA approval for that formulation before the year is over. So that's super exciting for, again, myopia enthusiasts and the Nexus group. Some other things that are kind of exciting is that the CHIMP organization, which is kind of like a preliminary organization to the European version of the FDA. They evaluate things that come through and kind of give an approval or a disapproval of the future FDA approval. And so the CHIMP organization in Europe gave positive approval, so there's opportunity for that to be available in Europe as well. And their STAR study, as you mentioned, went all the way down to 3 years of age, which is being able to have a safe medication for these early myopes is important. Again, thankfully, I don't see a ton of 3-year-olds, but I would like to have a safe option that I can tell parents, like, yes, it's been through the rigorous, evaluation of the FDA, and have that available for those patients, and being able to kind of know that I have a stamp of approval on that drug for these patients in the future. So that's, all good stuff related to atropine management. And there is some data around Ortho-K and Ortho-K plus atropine. They even here included some DIMS, which are spectacle lenses. And it just shows that, hey, if you have a kid who needs a little bit extra boost in their management, you can add in atropine and they get better. So their axial length changes at a slower rate when you combine the two methods together. And again, I add in atropine when I feel like I need better myopia control right now. So I have a handful of kids in, sort of each method where we're modifying the Ortho-K lens or adding in atropine. And that, again, that's kind of the art of making those decisions. And it comes with looking at the data, understanding your patients, and understanding the devices that you're working with, and, just committing to the literature, which thankfully to me, it's enjoyable versus a chore to look through that literature and really understand where the current data stands. One thing that just for if you're looking to learn more about those types of management, there's a website called Myopia Profile. It's led by Kate Gifford. She's a PhD, OD PhD out of Australia around myopia management. And the Myopia Profile website is really great at just giving you snippets of studies so you can kind of look and see which studies are most important to your practice. And grab that information in bite-sized pieces. So I really like that website to kind of stay up to date on what's new. Let's take a step back from, sort of active clinical care and just think about like our dream state myopia, where we no longer have high myopes, Vance, because we've, spread the good word, and now every myope is being managed. And so you're operating on a bunch of -3s. How would that impact your surgical approach if you were free from those like worrying about high myopes in surgery?
Well, we know that with, even higher, glasses corrections, it's sometimes harder to get the image quality that you can with a lower correction. And the same thing translates into, especially laser vision correction. The sweet spot is in the low to moderate nearsightedness. And once you start pushing it to those higher corrections, you can achieve zero correction, but your image quality may not be as crisp as what you dreamt of. And that's why it's, I've always said that even though we help people see without glasses through surgery, we're not a laser center. I mean, we helped develop laser vision correction. We did the FDA studies. We helped develop implant vision correction. We did the FDA studies. But I think going to someone who has a comprehensive understanding of what is the sweet spot for laser vision correction, and when is it time to look at something that is going to give you a better result for a higher correction, for instance, an implant. But when you're doing an implant, you're also, now going inside the eye. And so all of this involves, just like which way you want to correct your myopia, there's risks and benefits.
Mm-hmm.
And the same thing with surgery, there's risks and benefits. And in general, the lower the correction, the lower the risk. And so, there's patients that, don't have great options because their myopia became so high, or it damaged their retina, and I always say that if someone can get good vision with glasses or contacts, there's probably a surgical option out there to help them, get good vision without glasses or contacts if that's their choice. But if they've had a myopia progression to the point where now their macula or their area of sharp vision in their retina isn't working as good as it could have, there's not a surgical option that's going to change that. The prevention is the best. And so, having a patient population that didn't develop as much nearsightedness does make for more options for them surgically. It makes for safer surgical outcomes. And then even if we get into the cataract population, when you allow an eye to go unchecked in its nearsightedness, it's a longer eye. And there's, this is probably getting a little deeper than you want to get, but if you're a patient out there, when I'm doing cataract surgery, it looks like I'm looking at a trampoline with its little springs, and we call those springs the zonules. And those can get very loose in people with very high levels of nearsightedness. So there's actual physical changes that are lessened if their myopia was controlled earlier in life. So the benefits are amazing for starting young.
Talking about that, like the surgical safety of, a low myope versus a high myope. And sometimes I'll walk out of the exam room and, my technician who worked them up, took their images prior to their cataract evaluation. They're already jumping on board where they're like, too bad that guy didn't have myopia control 50 years ago, because they saw that, the myopia or their macula is distorted, or, various things. They see a bunch of, changes in the retina where because of their high myopia. And so even my team is getting on that too, where they're identifying that, gosh, like, too bad we didn't have myopia control and myopia management, 10, 20, 50 years ago. But thankfully the data continues to support these efforts, and it's going to benefit patients across all populations, all providers. And so it's good stuff. I kind of want to end on a note from a 2021 study about kids who use Ortho-K. They did a vision-related quality of life survey. I think it was called QUIRC, QIRC. And kids who used orthokeratology lenses reported that they were more self-confident, they were more willing to try new things, they were more apt or more excited about playing sports, which led to more outdoor time. And outdoor time in myopia is a whole nother podcast, and so maybe another time we can connect about that. But like, what valuable things, as you mentioned, kids that use contacts, they tend to mature in other ways when it comes to caring for their lenses. But I can use these tools to help kids become more self-confident. Like, why would I not want to do that? Like, what an amazing opportunity to impact a young child's life, not only in their eyesight, but also in the rest of their life. So that's kind of what I want to end on. And it's, if you're on the fence about considering adding Ortho-K to your practice, that should be enough to sell all of us right there, because that is probably the most rewarding part of it, is when these kids come back and they've basically changed. They're more willing to tell you about how they're doing, more willing to ask questions about their contact lens use. And, the parents are just so proud to see that change over a relatively short period of time. So again, if you're on the fence, I hope that helps you, be enough information to help you take that leap. And there's lots of good resources out there to help you. So with that, Vance, I want to thank you for taking, an hour of your day to spend with us, to talk about myopia, and I'm sure we'll get an opportunity to do it again in the future. So thank you all for joining us for the Advanced podcast series with Vance Thompson Vision, and we'll see you on our next one.
Thank you, Brooke.
Thank you for listening to Clear Answers About Clear Vision, the exclusive podcast by Vance Thompson Vision. We hope this episode has empowered you to take the next step toward achieving clear vision. If you found this information helpful, please share it with a friend who might benefit too. Ready to take the next step? Schedule an evaluation with our expert team or visit us online at vancethompsonvision.com to learn more. Together, we'll help you see the world more clearly, one decision at a time. Until next time, take care and keep your vision worth seeing.